Hi, my name's Dr. Jane Lockstone, and I'm based at Launceston General Hospital in Tasmania, Australia. And together with my colleagues, we undertook this study titled The Implementation of Physiotherapist-Led Lung Ultrasound on Physiotherapy and Medical Clinical Decision Making in Intensive Care Patients, a retrospective review. So, why did we undertake this study? Lung ultrasound is emerging as an important point of care assessment tool in the ICU setting. Evidence shows that lung ultrasound has excellent diagnostic accuracy when compared to other commonly used assessment tools, including auscultation and chest X-ray. More recently, lung ultrasound is being integrated into clinical care by appropriately trained respiratory physiotherapists. However, physiotherapy-led lung ultrasound is currently in its infancy, with wide variability demonstrated in clinical practice, both in Australia and internationally. Therefore, we wanted to evaluate the implementation of physiotherapist-led lung ultrasound on physiotherapy and medical clinical decision-making in our ICU. We used a retrospective review of a senior ICU physiotherapist's lung ultrasound logbook for successful accreditation with the Australasian Society for Ultrasound in Medicine. The logbook contained participants who were admitted to ICU between February 2022 to September 2022 at Launceston General Hospital and who had received a lung ultrasound scan as part of an assessment by the senior ICU physiotherapist. Data extracted from the logbook included age, gender, and reason for ICU admission, whether a lung ultrasound scan was clinically indicated, whether a lung ultrasound scan was positive, i.e. demonstrating pathology, and the impact of lung ultrasound on physiotherapy and medical clinical decision making. So what did we find? Well, the logbook contained 40 lung ultrasound scans. The mean age of participants was 62 years, with 65% being male. The most common reason for ICU admission was pneumonia, and just under half of participants were mechanically ventilated. With regards to the lung ultrasound scans, 65% were clinically indicated and 77.5% were identified as a positive scan. After a lung ultrasound scan, respiratory physiotherapy management changed in 27.5% of cases, continued unaltered in 30% of cases, and deemed not indicated in 10% of cases. The impact of lung ultrasound on specific physiotherapy respiratory management was not reported in 25% of cases. The respiratory physiotherapy treatment changes reported after a lung ultrasound scan included lung recruitment, airway clearance, patient repositioning, prone positioning, and physiotherapy-led bronchoscopy. With regards to the impact on medical management, after a lung ultrasound scan was performed, medical management changed in 20% of cases after lung ultrasound findings were presented or discussed with the ICU team, continued with no change required in 35% of cases, and the influence of lung ultrasound on medical management was not reported in 45% of cases. The medical treatment changes reported after a lung ultrasound included successful decannulation and/or extubation, modification of ventilator settings, and a delay in tracheal decannulation and/or extubation. So our small study suggests that the integration of lung ultrasound into physiotherapy respiratory practice may influence both physiotherapy and medical clinical decision making in ICU patients. This is through either a change in respiratory treatment or assisting the decision to continue with the planned respiratory treatment. Further research to prospectively evaluate the impact of physiotherapy-led lung ultrasound on clinical decision making, as well as key patient outcomes, is strongly recommended. Thank you.